So my lab for about a decade now has been focused on lobular breast cancer. I've been studying this type of cancer since my postdoctoral work. And we've been just for many years now really interested in how lobular has been really understudied and not focused on as an independent breast cancer subtype. But I think we as a field are appreciating more and more that that is the case, that there's a lot of unique biology in this cancer type. What got us onto radiation therapy and thinking about DNA damage response and how these tumors respond to this type of therapy is that my lab has been thinking about, independent of this question, we've been thinking about the estrogen receptor, which is the target of kind of the main backbone of endocrine therapies for breast cancer. And my lab has identified that there is a mechanistic interaction between the estrogen receptor and components of the DNA damage repair machinery in lobular breast cancer cells. And we're really excited to exploit that therapeutically. But it got us thinking about, with this interaction, how are cells responding to things that would target the DNA damage response, like radiation? And in talking to colleagues, we kept hearing piles and piles and piles of anecdote from physicians, from radiologists that, oh, lobular tumors are very radiation responsive, but we just realized that there wasn't anything concrete in any therapy recommendations or, not a lot in the literature on what that actually meant, what we knew clinically. So we decided it was time to try to put it all together in this review. And so we've identified that what we think is happening is that the estrogen receptor is kind of pulling one of the mechanistic cornerstones of the DNA damage response away from its day job, is what we've been calling it. And it's causing a defect, we think, in the initiation and propagation of homologous recombination, which is the main high fidelity pathway that cells use to repair double strand breaks, like those that would be caused by radiation therapy. We touched on it a little bit at the end of the review, that what we're seeing in these lobular tumors and in our cell lines and tumor models in the lab is that they don't look like they're the homologous recombination deficient, which is the kind of the classic phenotype associated with BRCA mutations, BRCA1, BRCA2 mutations, the so-called BRCAness. The tumors don't look BRCA-like at the kind of the gross genomic level, but as we dig into it, it looks like they kind of get to this point where they try to initiate these repair pathways and don't quite efficiently finish it. So we think it kind of helps them maintain the gross genome stability so they don't look BRCA-like. But then you hit them with something like radiation, and we're starting to look at drugs like PARP inhibitors, we think it kind of allows this latent phenotype to manifest. Right. So obviously not a physician. So, I'm like waxing philosophic as a bench scientist here. I think it's disappointing that that lobular cancer has kind of gotten cast aside as a no-go context for a lot of radiation approaches, in particular partial breast radiation. There's nothing in guidelines that say that patients with ILC should not get radiation. But we do think, based on the data that we've been able to find, that more modern partial breast radiation approaches probably should be investigated further, and we need more prospective data in that space to at least understand risk better and understand when lobular patients can get partial breast radiation and take advantage of the lower toxicity there. And if the relative benefit of radiation overall with lobular is indeed as pronounced as the data that's out there suggests, it probably should be pushed that we need to get past underutilization of radiation to treat lobular breast cancer. In that context, I think one of the things that we're learning about ILC is also that its metastatic pattern is different than no special type or ductal cancer. Lobular can tend to go to, in particular, abdominal sites like the ovary, the gynecologic tract, the GI, and it also goes to the leptomeninges. But it does first and foremost go to the brain, or I'm sorry, go to the bone. And I think what we don't have a great handle on, and we're just kind of assessing from retrospective data, is kind of the order of operations for lobular breast cancer metastases and when these sites can be effectively treated with radiation, whether we're thinking about oligometastatic disease, the presence or absence of visceral disease. So as far as what studies could be done, I think this is one thing we don't even have retrospective data There's no reports that we could find at all on lobular specific outcomes. So I think, over the past several years, we've started also accepting more what the diagnosis of lobular looks like up front. We've kind of gotten somewhat more standardized guidelines for histological definitions and companion stains, immunohistochemical stainings, things like Ecadherin to really define what's ILC. And I think as institutions now are going back and kind of doing central reviews of histology, some of that data will become out in retrospective analyses. I'd love to wax about, what kind of prospective studies we could be done, but really we just have nothing in the literature beyond anecdotes. So it would be really fabulous to have any sense of, if a patient with oligometastatic disease does get radiation therapy, what is the actual benefit there? Does it match the primary site? And in particular, because essentially all patients with ILC will get anti-estrogen therapy because essentially all of these tumors are estrogen receptor positive. How does that look for de novo metastatic disease versus recurrent disease after patients have received endocrine therapy? That's it. So that's a great question. One
Okay.
thing we're learning about ILC is that a lot of the markers that we would normally rely on to track ILC or to track breast cancer in general are somewhat more challenging for ILC, and it's something we're getting over. Kind of the most standard way that we measure tumor response in clinical trials is through RECIST criteria, which is physically measuring the dimensions of the tumor. But ILC, I think there's a really nice review out of UCSF that suggests that ILC resists RECIST because they're much harder to measure by standard criteria. So often patients get excluded from trials because they don't have quote unquote resist measurable disease. And that happens a lot for those abdominal metastases. Also, if you're thinking about things for metastatic disease like FDG PET using the glucose-based tracers, there's a growing body of evidence suggesting that ILC don't take up the FDG the same way that other breast cancers will. There's one particular study that compares head-to-head FDG versus a labeled estradiol, and out of all of the metastases identified, only a third of them were FDG positive as opposed to FES positive. So we know we're even underestimating by current imaging tools how lobular cancer responds to therapy, not to mention, again, patients being excluded from trials. So something we're really excited about, and I think that would be really great for advanced disease, for combination therapies, and for future radiation trials are things like circulating tumor DNA and circulating tumor cells. We know from the data that is out there in these that patients with ILC will often have higher CTC burdens and higher ctDNA burdens. We don't know what that means diagnostically or for outcomes yet, but it should be something that's potentially more measurable for these patients and getting a sense of therapy response. So really excited to see, as trials come out with using those markers to change care as an early diagnostic, we're excited to see those move into lobular because we think it's really ripe to stop excluding these patients from trials and have a more molecular-based diagnostic and to look at therapy response.